Welcome, Mallory Riggs from Mayo Clinic.
Thanks so much, Anne. I am a speech pathologist working up here at the Mayo Clinic in Rochester. I've been here for about 5 years, and I've also worked at Freighter Hospital in Milwaukee, worked at the ALS clinic down there as well. And I'm so happy that you're all here today, that Anne asked me to give a talk about swallowing changes with ALS. I am going to try to share my screen with everybody here. Oops, let's try that again. All right.
Looks good.
Okay, perfect. So we'll be following along with this. I'll try to keep an eye on the chat box throughout the presentation, but Anne, please jump in if you see something that comes into the chat that I don't see. So today, there were a few different things that I definitely wanted to cover in terms of swallowing changes. And I purposely left some time at the end of the talk because I think I want to make this useful for all of you. And so whatever questions you have, if there's, topics, things that we didn't cover, I really wanted to leave time to go over that at the end here. So just to get us started here, some quick facts that a lot of you may already be familiar with. With swallowing changes and ALS, most people who have ALS will develop difficulty swallowing or changes with their swallowing at some point. And we refer to this as dysphagia. So if you see that term in anything that you're reading or hearing, that's what that refers to. Swallowing difficulty can occur really at any point with ALS. Some people notice changes early on. Some people may have changes later on. It's really different for everybody. And ALS affects different muscles in the body through weakness or stiffness or both. And that can really cause some difficulty swallowing when the stiffness or weakness is happening in the tongue muscles, the lips, the muscles in the throat. Swallowing changes can worsen over time and can potentially lead to something called aspiration, so food or liquid going down the wrong pipe towards the lungs instead of the stomach. And for some people, aspiration pneumonia or a respiratory infection that's caused by something going down the wrong pipe. So it is something that we want to keep an eye on. Before we get into swallowing changes, I just wanted to briefly touch on what normal swallowing looks like, because it is a pretty complex process. And I think that'll just help to set the stage for some of the things that we're talking about, with changes with swallowing. So when we swallow, there are actually 26 pairs of muscles and 5 cranial nerves that work together to get food and liquid down from the mouth to the stomach. And it's a fast process. If we're looking at things going from the mouth down into the throat, that actually happens in less than 2 seconds. So it's very quick, but with all of those muscles involved, it also requires a lot of coordination. It's a really involved sequence of events that needs to happen at just the right time in just the right order for things to go down the way that it should. And when we're looking at swallowing, we focus on 3 main stages of swallowing. So kind of looking over here at this picture, if you can see where my cursor is, the first part of the swallow is what's happening in the mouth. We call that the oral stage. So chewing food, grinding it up, moving it around, kind of collecting it, moving it to the back of the tongue, getting things ready to swallow. That's what happens first. After that, the food or the liquid is pushed into the throat. And at that point, things are it's more of a reflex. It's involuntary. And that's called the pharyngeal stage of the swallow. And then the third part is what's happening in the esophagus. So that tube that carries things from the throat down to the stomach. So again, there's a lot that's happening when we swallow. And if any of those muscles are weak or stiff, or maybe both, like with something like ALS, for example, then a person will likely notice changes to their swallowing. And that, of course, is going to look different for every single person. Again, those changes can happen at any point in the ALS disease process, and it can look different for everybody. Some of the common symptoms that we see if and when swallowing muscles are affected are listed here. And this is certainly not an all-inclusive list, but a lot of times these symptoms come up pretty frequently. You might notice that meals are taking longer. It's becoming more difficult to chew food or to move it around in the mouth. Maybe it's just becoming more fatiguing. You're still able to enjoy everything that you want to eat, but it feels like more work. It's tiring. Maybe food is sticking in the mouth or in the throat, or maybe it's spilling from the mouth. So when you're chewing food up, little pieces falling out, or when you're trying to get, a sip of liquid ready to swallow, maybe that liquid is spilling from the mouth. Maybe you're coughing when you're eating and drinking. So that's, actually something that can happen to all of us from time to time, right? You take a drink of something, it goes down the wrong pipe, your body coughs to get it out. That's a normal thing that we all experience. But if that's happening on a more regular basis, then we wonder if there's a change happening with the swallow muscles. Maybe you've always been able to swallow pills no problem, and all of a sudden they're becoming more difficult to get down. Maybe it's harder to move them around in the mouth, or they're getting stuck somewhere on the way down. And weight loss is something else that we keep an eye on. It's, of course, weight loss can be associated with a lot of different things, and especially with ALS, it's something that can happen for different reasons, but there are times when weight loss happens because it's just too hard to eat and drink. And so why does all of this matter? Well, again, your body, you need nutrition, you need hydration. And if you're having trouble with eating or with drinking or both, that can lead to not getting enough in. And so it's something we want to closely monitor. I mentioned earlier the possibility of pneumonia, and I think it's important to note that not every person who has swallowing difficulty will, be at risk for this or will end up having this type of infection. But again, it's something that you don't need. It's something that we want to keep an eye on so that you don't end up with a respiratory infection from having things going down the wrong pipe. And then a big one that I think should be talked about more is the quality of life piece, right? So this is something, eating and drinking is something that we do every single day. And a lot of our social events, holidays, celebrations, there are a lot of things that we do with other people that include eating and drink or even revolve around eating or drinking. And so if you can't just go get a cup of coffee with somebody, or you're going to a celebration, but you can't eat those same things, or it's more difficult to eat those same things, that has a really big impact on you and your enjoyment of the activity. And so if there's anything that we as speech pathologists can do to help you with swallowing, make things a little bit easier, a little bit safer, that's our goal. So a swallowing evaluation, if you're noticing any of those changes that I just listed on the previous slides, or anything else that might signal a change to swallow function, your doctor will likely refer you to a speech pathologist, or if you're in ALS clinic, you're likely already connected with an SLP who is monitoring this, asking you questions, checking in every time you come to clinic. And so a swallowing evaluation usually has a few different components. A big part of that is the interview portion, or just sitting down and talking with you to get more information. What's going on? What's going well? What's not going well? We ask you a lot of specific questions about your swallowing, probably more specific than you ever thought possible, but it's all just to get a better idea of what's going on. Oftentimes we'll do a physical exam, looking at the muscles in the lips and the tongue, seeing how things are moving, assessing strength and range of motion, seeing how those muscles are working together. In ALS clinic, we'll likely also watch you eat and drink something, whether it's something that you bring into clinic or food that we have on hand. Watching you swallow different textures of food or liquid helps us get a better idea of what's going on with your swallowing. And then there are times that we might want to do something called an instrumental evaluation. So taking a closer look at what's actually happening on the inside when you're swallowing. And that can be done a couple of different ways. So this first way that I have listed here, this video fluoroscopic swallow study, that's an X-ray test. We'll talk a little bit more about that one on the next slide. That is sometimes also called a video swallow study, a modified barium swallow study, MBS, a lot of different names for that, but it's all the same test. Another type of evaluation. Oh, sorry.
Sorry, Mallory. There's a comment from Alan about the Lorna Doone cookies
Oh,
that
yes.
you get to have Lorna Doones
I
or
always have
graham
Lorna Doones
crackers.
with me, don't I? Yeah. Yes, in clinic, that's one of the things that we usually have on hand. Not the most exciting snack, but it gets the job done, right? So the other type of instrumental evaluation that we can use to look at your swallowing, again, seeing what's happening on the inside with those swallow muscles, is called a fiber optic endoscopic evaluation of swallowing, or a FEES exam. And so that's the one that's pictured over here on the right. This is not an X-ray. Instead, it uses a camera that goes through into the nose to the back of the throat. And then it looks kind of like a bird's eye view, looking at the throat as you swallow different foods and liquids. So the video swallow study, or that video fluoroscopic swallow study, that's what's pictured here. It's a really common test that we do. It's in the X-ray department, and it's nice because it's very quick. It's less than 5 minutes once we get started. There's no sedation, no IVs, no tubes or cameras or anything go inside of you for the test. What you do in the test is you swallow something called barium. So that's what's pictured here, this white stuff. We usually have a few different textures, so different consistencies of liquid, some different solids that have barium mixed with it or kind of spread on top of it. We watch you swallow that, and why we use that is because it shows up really well on an X-ray. Up here in this picture, this black is actually that white barium that we give you during the test. Regular food and liquid wouldn't show up so well, so we have to use that barium. But as you swallow those different textures, it's a live X-ray, and we get a real-time assessment of how your swallow muscles are working. So this is a great test for showing us if there's been any change to swallow muscles, if there's any muscle weakness, if there's any change to how the muscles are working together. We can see if food and liquid is going down the right way or the wrong way, or if it's maybe getting stuck somewhere along the way. This is a great test for showing us that. And another benefit is that we get the results immediately. We can go over those results with you. We have the information right away. And we don't always need to do this test. A lot of times, at least here at Mayo, this is a test that you might have done kind of early on when you're meeting with a neurologist and going through all of your diagnostic tests. There are times when we might do this at some point after you're established in the ALS clinic just to get more information. But oftentimes, once you're established and we're seeing you in clinic, we may not need to do an instrumental assessment like this. So whatever type of evaluation we do, whether it's that what we call a clinical assessment, which is watching you swallow some different foods and liquids, the X-ray test, or the test where the endoscopic test where the camera goes into your nose, whatever type of evaluation we do will really help us identify the problem and give us information about where it's happening. Again, is it happening with muscles in the mouth, muscles in the throat? Maybe both. And that'll guide us to, which strategies could be helpful for making eating and drinking easier for you. Because our goal is the same as yours, which is I want you to keep eating and drinking every single thing that sounds good to you as safely and easily as possible. And so a lot of these strategies are meant to help us along the way with that. A lot of times, the speech pathologist and the dietitian may work together because there's a lot of overlap in what we're talking about. we want you to be eating safely, eating efficiently, but also making sure your body is getting what you need. So in terms of the speech side of things, we'll go over a few different ways that we try to help you compensate for changes that might be happening. So some compensatory strategies, again, things that we have you try to make eating and drinking easier or safer or both. And I like to think of this in kind of two different categories here, right? So behavioral strategies, this column on the left rather, is maybe making changes or modifications to how you are eating. And then the column on the right, diet modification, that's making changes to what you are eating. And I think that's always, we don't want to jump right to changing what you're eating. If possible, we'd like to try these things in the left column first, changing how you're eating, because again, I don't want you to change too much about what you're enjoying. So these are just some examples of different strategies that can be used. Ultimately, it's very individualized. Your speech pathologist that's working with you would let you know which of these could be helpful, which of these maybe to avoid, and likely would try them with you. But some of those behavioral strategies are just eating and drinking slowly, taking small bites and sips, things that maybe sound kind of common sense, but a lot of us don't do, myself included. I tell people all day, every day, take your time with eating, take small bites and sips. And then I head back to my office at lunch and I inhale my lunch. So it's a hard thing to get out of the habit of doing, but that can really make a big difference, slowing down and taking smaller bites and sips. If you're noticing that little particles of food are maybe getting stuck in your mouth or stuck in your throat, taking a drink of liquid, what we call a liquid wash, can be helpful for getting those little particles down. Maybe changing your head position. This is definitely one that your speech pathologist would need to weigh in about, but sometimes keeping the head in a neutral position rather than tipped back, or even tucking a little bit towards the chest can be helpful for some people. It's not helpful for everybody, which is why we like to try it with you. Multiple swallows can be helpful if the muscles are just overall a little bit weaker than normal. Usually if we take a bite of food or a sip of liquid, all of that food or liquid goes down on the first swallow. But if those muscles are a little weak, it might take a couple swallows to clear everything. And then clearing your throat after swallowing, that could be helpful if, say, on one of those evaluations, it showed that food or liquid was getting close to your airway at some point during the test. Clearing your throat can help get the food or liquid away from your airway so that it doesn't go down to your lungs. Some types of diet modifications that we look at, again, trying not to modify too much about what you're eating, but maybe initially, if dry and crumbly foods, that can be tough for a lot of people. Those little pieces just want to get in every little pocket in your mouth and in your throat. So either avoiding those dry and crumbly foods or adding some moisture to it, like a sauce or a dip or a condiment, or, dunking that cookie in a cup of coffee or milk or something just to add moisture. Sometimes that's all that you need. Maybe avoiding what we call mixed consistencies. So those are things that where there's solid and liquid in the same bite. Examples would be like a chicken noodle soup or breakfast cereal, some cold breakfast cereal with milk, right? When you take a bite of that, the muscles in your mouth have to manage a solid food, whether it's the cereal or the chicken or the noodles, and the liquid at the same time. And sometimes that can just be too much if the muscles are a little weaker or a little stiffer than normal. For some people, soft foods are much easier to manage. It requires less work, to chew something that's soft. If you think of meatloaf versus a steak, right? Meatloaf, it's much easier to kind of mash down, doesn't take as much work. And thicker liquids. This is, if you think back to initially one of those first slides talking about normal swallowing, the swallow happens really, really fast. It's less than 2 seconds and everything is down. And so if those muscles are weak or stiff and they're maybe moving slowly, it can be hard to handle things that also move quickly, like a cup of water. If you have a cup of water and you picture pouring that, that water moves really fast. If you have a milkshake and you pour that milkshake, it's still going to pour, but it moves a lot more slowly, right? So some people find that thicker liquids, they move more slowly, they can be easier to swallow. So a little bit more information on the thicker liquids here. Again, this is something that your speech pathologist would go over with you and figure out what works and what doesn't work. But sometimes in this bottom box here, just these naturally thicker liquids may be something that we'd have you try to, again, compare, see, is this easier? Is it about the same? But some of those naturally thicker liquids that you could just buy at your grocery store would be like these smoothies. A lot of these are found in the produce section of your grocery store. A drinkable yogurt, a homemade smoothie. I know it's June and we're not thinking about eggnog, but that's also a thicker liquid if you think of that consistency, or even just a full fat milk. Like a thick chocolate milk is definitely thicker than your morning coffee. This top column, I don't think too many people rely on this, but if you have a savory food like a soup, you can also thicken that up a little bit, just adding in some instant mashed potatoes or a little bit of cornstarch and flour, like when you would make a gravy. There's also something you could do specific to soups with an immersion blender. So that's like a stick blender. You could even do it with a regular blender, just adding a little bit of your soup to that. But oftentimes, if you blend a portion of your soup, say a chicken noodle soup, it thickens the base up enough that you don't have such a stark contrast between the very thin broth and the solid pieces of soup. There are also different types of thickening products that are available to make thin liquids a little bit thicker. So this would be for something, if you definitely know that thicker liquids are easier to swallow. Again, your speech pathologist could give you more information about this. But there's ways to make your coffee, your juice, a little bit thicker. And so there are different, we call a thickener. It's maybe a gel or a powder, something you would add to your liquid. You can get those online, of course. A lot of pharmacies will stock the powdered thickeners. And you can also buy products that are pre-thickened. So without buying the powder or the gel, you could just buy a juice or something that's already pre-thickened. It's a little bit more expensive, but less work to prepare. There are also some adaptive aids that could be helpful for, again, modifying maybe how you're drinking your liquids and not so much changing what you're drinking. So for some people, it's much easier to take a small drink of liquid rather than a big gulp. Maybe you're having coughing, maybe things are going down the wrong pipe with a big drink of liquid, but perhaps with a smaller sip, things go really well. There are different cups and straws that are designed to measure out just a small sip if it's hard for you to do that on your own. So here's one example. This is called a Provale cup. It, again, measures out a small sip. Or these attachments that would go on a drinking straw. Again, measures out just a small sip. If sip size isn't an issue, but what's hard is maybe getting the liquid up into the straw, right? It's a lot of work to suck that liquid up every single time you need to take a drink. They also make different straws and straw attachments that can keep the liquid in the straw. So this is one example. You would just put it on the bottom of your straw. You take your drink, the liquid fills the straw, but then it stays in there. So the next time you take a drink, you don't have to draw the liquid all the way up from the bottom again.
There is a comment
Oh,
about that
thank
Dallin
you.
says V8 is a thicker liquid that
It,
seems easier for me.
yeah, absolutely.
And we do have these straws in the loan pool. Just have your speech therapist, your SLP in clinic, make that request. We're
That's
happy
perfect. I'm so glad you mentioned that. Yeah, and I think you guys also have these nosy cups too, right, Anne? I'm pretty sure These cups,
We sure do.
yeah, if that head positioning is really important, right, helpful for keeping your head in a neutral position, if that is helpful for eliminating coughing with liquid, we have these cups here with the cutout, which is where your nose would go if you're taking a drink. So with this cup, if you want to get the last drink on at the bottom, instead of tipping your head back, you can just tip the cup back. And because this is cut out here, it won't bump into your nose. So that's, again, a little different, but a few options for adapting or changing how you're drinking your liquids instead of changing what you're drinking. And then the last thing that I just wanted to briefly touch on, because it does come up pretty often in our conversations about swallowing changes, is the feeding tube. And of course, this is always part of a larger discussion with many other people on the team, your doctor, your dietitian, the respiratory therapist. But because it always comes up in our conversations, I just wanted to touch on it. One important thing that I like to highlight is that whatever you decide about the tube is definitely your decision, but just know that having a tube doesn't mean that you have to stop eating and drinking. You can definitely do both. And so a lot of people actually do. Maybe just for getting medications in or making sure that you get enough hydration during the day. We can still work on these other pieces of swallowing, right? How can we modify, make things easier for you to eat and drink? You can also have a tube at the same time. We just want you to be asking questions about it, letting us know your thoughts on it, your feelings on it, because we'll support whatever you want. But knowing your decision and your thoughts definitely helps us tailor the recommendations to you. All right. And so takeaways here, just to summarize, I think the big thing to take away is just to monitor for changes. We don't want you to be afraid of eating and drinking, be overly cautious and restrictive, but just monitoring for some changes can be really helpful. Letting your speech pathologist know in clinic if you're connected with clinic, just so we can try to make recommendations, again, that make eating and drinking easier, make it more comfortable for you. Knowing about these things, these changes early on is most helpful. And if you aren't connected with an SLP in clinic, you could always request that referral or reach out between visits too with any concerns that come up. All right, and I think I must have talked much faster than I had planned to because I'm ended a little earlier than I'd planned, but this is still good to have enough time for questions and comments.
That's right. I am going to
stop sharing here. Yeah.
Thank you.
Yeah, so that's a great question about the timing of feeding tube placement. And as you acknowledged, it is a broader conversation with other people on the team, but I think a few different things that we usually keep in mind, like you mentioned, the forced vital capacity or your respiratory status, because it is a medical procedure and safety has to be a piece of this. It's a factor into it going through a procedure. But other pieces I would say in terms of nutrition and swallowing, some factors that we look at would be, are you losing weight without trying to, despite, if you're supplementing or trying to optimize your nutrition as best you can, are you still losing weight? That would be a time to maybe talk more with your team about it. Or in terms of the swallowing, are you having more difficulty? Is eating and drinking, does it feel like a chore? Are you taking a long time to eat and drink? Is that a big part of your day, is just spending time eating and drinking? I think those are also times that we would want to, or be good to talk about with your team. I know it's not very specific because it'll be different for everybody, but does that help clarify at all?